Nageshwar, we can see you.
Yeah, can
Welcome
you hear
again.
me?
You're part of TCT. Thanks for organizing all these pediatric sessions. All the stalwarts are there in front. You know all of them. You worked very closely with them. And we have Dr. Krishna Kumar, Shiv Kumar, Bharat, and Kavita Madam, others, Jairangnath sir to moderate on this side for your live case. Over to you, Krishna Kumar sir, and you can take over and conduct this live case. Thank you, Nageshwar, again.
Thank you very much. Good evening, everyone. Dr. KK, Dr. Bharat, Shiva, Jairangnath, Dr. Kavita, thank you very much. Indeed, it's a great meeting from adult TCT point of view, but they requested us to conduct a couple of talks and then live case, even though I know it's a pandemic, a bit difficult, but in view of TCT theme, I thought we will show one case. So, can I show the audio visual and then Dr. Bhargavi will present the case. Before that, I would like to introduce my team members, Dr. Shweta Bakru, Shweta, Dr. Pavan, and my chief cath lab technician, Pavan, Hemant, Naveen, and Raghu. We have a senior anesthetist, Dr. Patil and Dr. Yogesh here. So, Bhargavi, I request you to present the case details and show the
Yes.
details.
Yes, sir. Good afternoon.
I'm very happy Nageshwar has become entrepreneur, also part of the hospital. Video is also coming good, and after that we'll have his presentation.
Yeah. Good afternoon, everyone. Today, I'm Dr. Bhargavi. I'm presenting a case. So, we have an 18-month-old child who is asymptomatic, referred in view of murmur. Pulse was regular, normal volume, heart rate was 90 per minute, saturations are maintaining at room air, blood pressures are 104/60, and weight of the child is of 10 kilos. And there is an ejection click and ejection systolic murmur 3/6 is there, and faint continuous murmur. So we can see the X-ray, which is having normal CT ratio with normal pulmonary vascularity, and the ECG is also showing sinus rhythm and normal QRS axis with RBBB is there, and there are S waves in V5, V6 also. So here is the echo where the four-chamber view is showing dilated left heart, and there is mild mitral regurgitation, and here we can see there is coronary, left coronary system is hugely dilated, and in the second video we can see that there is a track going downwards posteriorly, and it is opening almost near the coronary sinus. So this is the picture where we are seeing the track, fistulous track from LCX. It is coming and joining in the coronary sinus with a Doppler. So this is the child, and this child also had a doming pulmonary valve with pulmonary stenosis of gradient of 50. So CT angio we have done. So CT showed it's a coronary cameral fistula from left circumflex to the coronary sinus, which is going all through the AV groove and running into the posterior coronary sinus. So it said the fistulous tract was measuring around 6 mm. And these are the CT pictures imprinted, which is showing the LCX, and this is the fistulous tract going posteriorly, and from above if we see it's posteriorly and draining to coronary sinus. So this is the schematic diagram which the LCX is going down posteriorly and then to CS. So we have done prior cardiac catheterization, which showed there is a valve gradient across pulmonary valve is 20. So blood pressures 104/56, FA pressures with mean of 72, and cubic EOS, which is most important, is 1.5. So our diagnosis is a coronary cameral fistula circumflex to coronary sinus with a QPQS of 1.5. So now our plan was to go and do the transcatheter closure of the coronary AV fistula. Next to Nageshwar sir.
Yeah, thank you very much, Bhargavi. We will show you the pictures what we have done. We have right now child is anesthetized, general anesthesia, intubation. We have 6 left femoral artery and 4 femoral artery, and right 6 and left 4 femoral, and jugular vein we have taken. Our plan is to go and close the fistula as distal as possible using a conar MFO device. We will show the pictures and we will take the plan from you also. Show the angiogram, first angiogram. Yeah. So you can, is it seen? Yeah. You can see this is the AP view using the pictal catheter. You can nicely see the fistula which is going through the AV groove and then to the coronary sinus at its opening into right atrium. There is a left coronary artery we can see nicely. We can't see OM branches from the circumflex artery here. So next. So yeah, go, yeah, stop. So run that. So what we have done is we took a 6 guide catheter and we advanced guide catheter as distal as possible, and we snared the wire so that you will get a good support without damaging the coronary vascular system. That is the whole idea, not to deploy from the jugular, but still you can deploy from the jugular as well. Put an additional PTCA wire and we put the 4 into 12 balloon there. This is a coronary balloon. Next angio, show the next angio. So that is the balloon occlusion angio in AP view. You can see the balloon occlusion angio in AP view. Left coronary LAD is seen, circumflex is giving branches as distal as possible. The last OM 4 also I can see there, and that is the mouth there. Show in lateral view. So this is the lateral view is quite encouraging here, because we have a space there, landing zone, where the last OM to the constrictor segment landing zone is there. So that is what encouraging me to put the device here, taking conar MFO, because we want to do that, but we can take opinion at this point of view. KK sir, you can please discuss and suggest also.
Yeah, that's a reasonable option. You want to go through the vein or you want to go through the artery?
We want to go through the artery.
Why did you take 6? You could have taken 5. This is a small child, right? You could have taken a 5 guiding catheter. And
yeah, 10 kilogram and 18 months baby. I do agree with 5. 5 will take 7.5 conar MF device as well. But it was taken 6 at that point of time.
Okay, that's fine.
Yeah.
So you want to go via the arterial approach or the venous approach?
We would prefer to go arterial approach here at this point of time. We can still go from the venous side.
Would you retain the coronary wire while you're doing that, or would you take out the? Would you take out everything?
That is one of the reason why I kept 6 guide, sir. Because if I keep coronary wire, the 8-6 device will not go, whereas 7.5 device can go. So that is the reason I thought we'll keep a 5-6 guide catheter in case of eventuality, buddy wire technique and all. That is the only reason.
Does anyone else have an alternative thought?
Nageshwar,
how to do this?
Nageshwar?
Jay, good evening. Nice to hear your voice. I am seeing you also, luckily.
Yeah. Okay. Thank you. No, why you did not think of doing only from the venous approach? Why did you electively have taken the 6
Yeah,
or the
venous
arterial?
approach we can do from the jugular vein. I do agree, but I can't do from the femoral vein because this is a posterior
No, femoral vein is not at all the option here. We also had a couple of them. I think always we have done through the jugular only.
I will tell my viewpoint why I want to do from arterial side.
Yeah.
Venous side, I want to put a disc and pull as much as possible close to the coronary fistula. I don't want to occlude totally the coronary sinus. So I want to leave a little bit of space there so that the coronary venous flow, even though people say it's not an important aspect, but I prefer a little bit of coronary space, venous space there so that it can drain. That's the reason I thought I'll pull the device as much as possible close to the arterial side. And then we can push, once you pull this, we can push the arterial disc away from the OM. If you are doing from the venous side, I will not have much options of pushing the low pressure disc close to that, because it is a non-centered disc. So that is my thinking.
The device, the
Can I make a,
exit point. Sorry, please go ahead, Bharat.
can I make a comment?
Please.
Yeah, the only comment I wanted to make is that when you close these distal fistulae with such dilated proximal tracts, with the vessels, branches being given right up to the end, be careful about slow flow and no flow following plugging these distal holes.
Yes.
You may get into serious problems sometimes. So you have to be careful that you don't cause this kind of a complication.
I will definitely take your point, sir. And also we have experienced one of the case a long time back at a care hospital closing a LAD fistula. We had to give procedure intracoronary urokinase as well. That's a very valid point, because this fistula is distal fistula and the entire circumflex is uniformly dilated and ectatic.
And one more point I wanted to make, Nageshwar, is that if you look at the world literature on coronary fistulae, the long-term follow-up of patients in whom the fistulae opened in the coronary sinus, the incidence of sudden cardiac death in the follow-up period has been maximum. So when you counsel these families, you need to be a little tactful what you are actually telling them when you close this fistula. This is just to...
Any idea why coronary sinus fistulas are?
I don't know. This is just an observation. If you look at the series of patients which have been published from various centers, Cleveland Clinic, or if you see the series coming from Boston Children's, if you get together all the data, you will find that in the long term, the maximum incidence of accidents happening in long-term follow-up has been always a fistula opening into the coronary sinus. Just an observation.
Yeah,
I don't know the logic.
that part I don't know, but whenever there is a, as you said, that distal fistulae with the ectatic segment, I have also noticed in some of the published literatures, as well as people, Shack also presented one of the case, developed thrombus and all. I do agree, I will take that point and definitely will keep the child on oral anticoagulants. So,
go ahead.
Yeah, we'll go ahead with the procedure.
Yeah, I think we should
Yeah,
stick
we
to
will
this
not
wire.
waste. Shweta,
Go ahead. There are 6 of arterial sheath. Please finish the procedure quickly.
So we'll just hold the thing, pull that little bit. So we'll deflate the balloon and then remove the catheter. Then I will remove that wire. Yeah, hold this. Yeah.
Election.
I will remove this arterial catheter also. Once you do that. Okay. So, Pawan, little bit loose the wire there. I would like to go a little bit high up. Okay. Now, can you remove the other wire as well? Push the wire. Yeah. Okay, please load the device. 75 MFO. Okay. P2 on. Give P2. So please show the device. Shweta is loading a 7.5 device, 7.5 MFO.
Nageshwar, show which end you're going to
Yeah.
load. That's also very important. So you're going to load the.
So there are two discs. The people, adult cardiologists who are not familiar with this device, the device has got two discs. You can see that one is called as a high pressure disc. It's a conical end connected with a narrow segment to the low pressure disc. So low pressure disc, any arterial, any venous structure we can put it wherever the pressures are low. Whereas the other side, her right hand side is the high pressure disc. Since we are doing from the arterial side, we are loading to the arterial side. This device has got retention screws on both sides. So you can deploy either from the arterial side or from the venous side without adjusting the device or tilting the device, unlike your muscular VST or PDA device.
You've chosen 7.5 because you measured 4 mm as your exit point?
Yeah, absolutely correct, sir. So we will try to go through this buddy wire. Hopefully it allows us. If it doesn't allow, then I am willing to remove that buddy wire.
You know, what would have helped a little bit was to snare the buddy wire at the jugular vein. You would have had greater control in this situation.
Yeah, that also an ideal option, but the small wire snaring, yeah, can be done. Oh, it's going easily. So that's a good thing.
Yeah, that's the biggest advantage of your device is the profile. You can take it through guiding catheters, and that gives you tremendous flexibility in a number of situations, which is why I use it very often nowadays.
So can you show the lateral angio also? Please go.
Please show the angiogram. We are only seeing the groin.
Okay. Please show the angio. Please show the
good. Now we can see live. Don't worry. You can see live. Your device is reaching the middle of the circumflex and it's going
little bit tightness she is feeling, but however manage.
You will feel, because at this point is where you feel the maximum resistance when you have buddy wire, and that is the slightly difficult part of it. And you will also experience difficulty in taking out the wire once your device comes out, Nageshwar, and it can be very challenging. So I would encourage you, as soon as your device is slightly out, to remove the wire.
Just go gently.
Because it becomes very difficult to take it out once your disc expands.
So what we will do is we will show the lateral and go to lateral, remove the buddy wire.
Yeah, go to the lateral and remove the buddy wire. That's correct.
Please
you have to go a little more inside.
Yeah.
Little more inside.
Show the lateral angio by that time. Lateral angiogram. Yeah, you can see the lateral angiogram.
Yeah. Go ahead now. Table down. Yeah. Down, further down, table down. That's good. Now you're in pretty good position. Just need to come out a little bit more. There's a little bit of a challenge out there.
Yeah.
Yes, excellent. Now you can pull out the wire if you can. If it's
So,
coming out, please pull it out.
Yeah. Shweta, you can pull out the wire and then pull the entire assembly. Then we can do the, unlock this and pull.
Yes, that's good. You know, it will really, I've had trouble pulling out the wire once the device is deployed. Excellent.
So we will do one injection once I snug the device to the disc. Little bit table down.
You cannot see too much.
Down, table down, and push towards that. Yeah, table up now. Cut. Yeah. Are you ready to give injection?
I'll just flush out once.
Yeah.
You have space for the injection? That's good.
Yeah. Ready? Yeah. Contrast. Where is contrast? Okay, okay, okay. Ready?
I think you're in good position.
So what do you feel?
This angiogram where we had the baseline angio, so that you know exactly
Can
where you
you?
are.
Yeah.
Like you're
So
deploying it, but go ahead.
I'll just deploy a little bit here. I'll not pull
The only
anymore.
concern I have is your retention disc on the other side may occlude the coronary because it's a long device and it's not forming.
Yeah, I expected that. Device will not be formed because the track, the device will adjust as per the requirement of the fistula track.
Than what you have.
Now can you do the angiogram here? BP is okay, heart rate is fine. Ready? You can you can use contrast only, don't use injections.
Okay.
Ready?
Yeah.
Okay, let me
Looks
check.
very good.
I'll
Can you
come
just
back.
withdraw slightly? Yeah, withdraw the catheter so that
Yeah.
we see how the coronary branches are.
Now ready? Contrast only. Take 5 cc. Ready? Yeah, the device always will be what is that?
There's one branch
Yeah, I agree. The last.
which probably could not have avoided. That is absolutely at the very end. You can see that branch, Nageshwar.
I can
It's
see
coming at
last
the junction
OM. Last
between the
OM
middle
is
of
getting occluded.
the high pressure disc between the stem and the retention skirt. You have the small branch coming out. Other than that, you're okay, I guess.
So what, Bharat sir?
Only concern
What
is
about others? There's like a pretty stony silence. Bharat?
yeah. My only argument was we will never know the exact.
Bharat, you're not audible.
Oh, I'm sorry.
Jay?
I'm not on mute.
Shiva? Others can just.
Yeah, I can
give
hear
their
you, sir.
comments.
Shiva is there? Shiva? Shiva is there? Jay?
Hi, yeah, I'm here.
Jay, the last OM, the distal OM, that is OM4 is small.
Yeah,
So
very
that is
small.
getting occluded. So
Yes,
can
yes,
we remove the device or we'll accept it?
It's a very small branch. It's the last branch. I think it's okay.
You are probably going to sacrifice that.
Yeah.
I don't know. I mean, at this point, I'm not.
Maybe
Right.
we will ask adult cardiologist, adult interventional cardiologist.
Nageshwar, you should not remove the device because you'll do a fair amount of damage at that position if you want to retract the device and you have to start all over again. So you
Okay.
have to take a call.
So
and I think it's a small child to go through that fistula again and again.
Okay.
I am not going to advocate removal.
Okay.
Can I have comments from Shiva, Bharat, Kavita, others?
My
Would something with a single disc work, like an ADO work?
Yeah, so I would have actually personally used the ADO AVP4 in this situation because it's a little low profile. But I think that's fine. I think the choices
No, I
are
thought
okay.
AVP4, but we are not using, we did not consider that because of a high flow embolization may be possible. It's a very low profile device. So I
Yeah,
thought
it is low
about that.
profile. The other option would have been to use ADO2 additional size. It would have worked very well for you because it's much.
Otherwise,
more
KK,
compact.
even the AVP4 around 6 mm or 8 mm,
Yeah,
6
would
mm
have
device
done
would have done a good
Yeah,
job.
would have done the job
it could
because
have-
what I use
could have
as
formed.
Yeah, it forms. But
Ah.
at this point,
Jay,
I
the
think
device will never be formed.
No. See, here what is happening in your case is that 7.5
retention
device, but what is the retention skirt? Retention skirt is plus you have to add, no?
Plus it
7
is
plus
2.5.
No,
Plus
I know,
2.5.
2.5. 2.5 means how much it comes? On both the
2.5,
sides.
it is 9.5.
9.5 to 10.
Yeah.
So use a 6 mm or 8 mm device, AVP, it would have certainly formed.
Yeah.
Because if you see, the very fact that you used a coronary balloon to occlude it, a 4 mm balloon, it cannot be more than 4 or 4.5 millimeter, that narrowest part. You could upsize by to 6 or 6.57.
So we'll give one angio now after 5 minutes. Can you please give one more angio? What I mean to say, to avoid that small branch, is it possible with AVP2 is the question. AVP4 I agree with KK, but I did not consider that because of the low profile. But it is possible, you can position it also, I am not disagreeing with that. Angio. So that is the issue. I will pull the catheter more and then see how the left system, entire system is failing.
Nageshwar, I don't think you should do anything more. I think you should.
Yeah, one angio I am doing here, the last angio. Ready? Yeah. So we will deploy the device here.
You should deploy it here.
Okay. Hold this. I will go catheter little bit in. Child is moving.
Yeah, you should go in before you release it.
Yeah, you can deploy now. We'll just wait for 1 second.
Put some traction towards the device so that will enable you to be more in alignment.
To adjust the table. Okay, just wait. Yeah, please deploy.
It's going to take a little longer because there are quite a few twists and turns in your catheter. So it will not be easy to unscrew it.
Yeah.
You have to pull it a little bit. Yes. No, I think you should stay there and do an angiogram.
Okay. We'll do one here, one angiogram, and then we'll think about. Is there contrast in that? Okay. Yeah. Ready? So I think position wise, as we are thinking, because device cannot be formed in this particular situation of retention disc of what Jay was telling, 9 millimeter cannot be. Whereas AVP2 maybe one disc this side, but still you will have same disc. Suppose AVP2 you put 8 millimeter AVP2 because it's a
Nageshwar, I don't recommend AVP2. AVP4 is what I would have used.
Okay.
I would have used the AVP4 6 or 8 mm, and I would have had one Hershey chocolate inside the right ventricle, in the right ventricular side, and one Hershey chocolate will be inside the on the left side.
Yeah.
And usually with that, between the two discs, you can get a reasonably good occlusion. I think for the coronary fistula, I have found the AVP4 is the best suited because it doesn't have retention discs.
Yeah.
So it just plugs very nicely.
No,
and,
otherwise,
this is a reasonable result. I mean, I don't think it's a bad result at all. It's just one very small distal vessel, which I probably shouldn't matter. All the points raised by Bharat are very valid. You have a fairly dilated, coronary, which could thrombose, and you need to watch this very carefully.
No, I just want to give a comment that coronary MF device adjusts as per the vascular structures. So whenever we are using in any collaterals, fistula, or any veno-venous channels, please don't expect the device will be formed. Device will be adjusted as per the anatomy, morphology of the vascular structures. So that's why it is behaving like that. We cannot have a bigger device in a small vessel and have the device which is formed. So that is happened in this situation because constriction portion is only 4 millimeter and other area it is 6 millimeter. We put a reshunt and disc of 9 millimeter. So if it is okay, then we will come out then.
You have to come out.
Yeah.
I don't think there's anything else
Thank
we
you
need
very
to
much for your valid comments. Thank you, Bharat sir. Thank you, Jay. Yeah, please put the wire. We'll remove the thing. If there are any questions, Dr. Srinivas Kumar, are you there?
What is going to be your antiplatelet or anticoagulant regimen in this patient?
This patient, I think because it's a distal fistula and a lot of aneurysmal segment of circumflex, I would prefer to give warfarin for 6 months. After that, we will give lifelong antiplatelet medication. You may ask one, sir?
My other question, Nageshwar, is that since the device is not well formed and it is kind of got elongated, what are the chances that the residual shunt might persist?
No. I already told you device will never be formed. Even you take AVP2, AVP2 device will not be formed. It will configure to the vascular structure. Unless we put like a VST or AP window or PDA, this device in vascular structures will never be formed. It will be distorted. Now the residual shunt, because there is no fabric in this, there is no PTFE or what is that Dacron in up to 86 devices. So the occlusion rate is very fast. Within 24 hours, more than 95% will be occluded. In the first week, close to 100%. Recent Philippine data showed that 99% occlusion rate in the first week itself. So occlusion will be very fast. There is no problem. We think that
it always occludes. That's not actually. It's a good thing to have a period of slightly residual flow in these situations. It allows the flow to happen till such time. I think it's not a bad thing at all in this situation to have residual flow, but it doesn't matter, I guess.
Because you were going to use warfarin, that is why I was a little concerned with without PTFE use of warfarin and a residual flow. That's the reason.
We will.
I take your point on that. I take your point on that.
We will definitely do the echocardiogram and see that residual leak is there or not. If the if the residual leak is there in worst case scenario, then probably case to case basis we will consider. We will give only antiplatelet aspirin. We don't give dual antiplatelet in children in our institute. Aspirin will give 3 to 5 milligram. If it is closed completely, then definitely we will give warfarin in the distal fistula, like this entire segment is dilated.
So on hindsight, let's go back to that question on should we have closed this fistula, because you're balancing 1.5:1 shunt with having to give aspirin and warfarin for some period of time in a small child. I just wanted to bring it up only because I thought we should. We can't just shy away from this argument. Some of us would have closed it, but we really have to think.
I agree that point. Coronary fistula transcatheter closure indications. Obviously, if there is a heart failure, any age group we should do. Asymptomatic patient, if the QPQ is lesser than 1.6:1, we have to wait till 10 kilograms or at least reasonable age where catheterization technique should not harm the child, like 2 years above. So we are also closing this baby is grown reasonably well, 18 months plus and then 10 kilogram above. That is the reason why we actually indicated. We are following this child right from the birth actually. So we have been following and then we thought we will do appropriately this particular age. I definitely endorse and agree that in infants and young children, before you doing the fistula, justification and indication. On the other side, I would like to tell one more point. We had a coronary fistula child, it's an adolescent, not child, and following for long time, developed one day, came with MI. So that patient actually we had to give thrombolytic therapy. Subsequent, it was actually fistula to pulmonary artery, small fistulas, many fistulas.
Anyway, let's take a vote amongst the people who are present here. Bharat, would you have closed it at this stage or would you have waited?
I'm a little more conservative. I'm not as eloquent as Nageshwar in handling the catheters and all in small babies. I
Jay,
would have probably waited a little longer.
Jay, what would your approach would have been? Close or wait in this child? This is a real borderline. I want to tell you that.
No, really borderline. I agree with you. Maybe.
See, actually, it's easy to know when you have the data 1.5:1. Often we don't have the data. You take the patient to the cath lab and then you don't want to catheterize again. So personally, I might have actually closed such a fistula. I'm not trying to say that I won't do such a fistula. It's like totally borderline. But I just want. I think we all have to collectively acknowledge, for the sake of the audience, that this is a case where it's a bit tricky to take a decision, where we're balancing benefit versus harm. I think
because you can be damned either ways.
Yes, either ways you can have a problem.
Because remodeling of the arteries, sometimes the remodeling of the arteries and the aneurysms growing very rapidly in children is not uncommon. One of the reasons why these fistulae are closed early is for that, because the remodeling of the arteries is huge.
And also I want to tell that if it is a end artery fistula like this, the aneurysmal segment is going to be continuous process.
Absolutely.
If you close
that is the point, I think, which justifies you doing it, Nageshwar, now.
Yeah.
Because you take another couple of years, this will become completely aneurysmal. Then the likelihood of thrombus is even higher. So by closing it now, you prevent subsequent dilatation. I think that may be a reasonable justification in doing it. But I have to say the jury is out. All of us are not sure. Let us be honest about it. Collectively, we have to acknowledge that this is a bit of a tricky situation. Kavita.
Yeah, I would agree with you, but maybe, wait a little longer for the child to get a little bigger.
Okay. All right. So I think, I still think it's a very well done job, Nageshwar. Shows the versatility of your device. Truly multifunctional device, which you can put in a variety of situations. Good technique that you demonstrated that everybody can learn from. The point of making a wire, snaring the wire, but yet delivering from the artery, using a buddy wire, getting as distal as possible. All those things beautifully demonstrated, and great case. Thank you. Very well done.
Thank you, sir. Thank you.
Thank you, Nageshwar.
Thank you, Kavita.
Thank you, Nageshwar. See you.
Thank you, Jay, Bharat sir, all.
Namaste. I am Dr. Srinivas Kumar, the Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings best wishes to you from FACS Foundation and TCT India South Asia 2021 conference. In a part of our live case learning series, we bring to you another interesting case of a congenital heart disease, the large coronary arteriovenous fistula, which was managed very well, closed by percutaneous corner MF device by Dr.K.Nageshwar. This was shown from Rainbow Hospital, Children's Hospital, Hyderabad. What was initially discussed was regarding the patient presentations of heart failure and initial stabilization of the children. And then the panel also discussed that unless the shunts are more than 1.5:1, we generally need not close it, because this closure of the fistulas could also have some complications in the long term, as was being highlighted by Dr. Bharat Dalvi. Dr. Nageshwar effectively showed how to diagnose this on echocardiogram and how to assess this by doing an angiogram, and the point of entry exit of the fistulas were very well shown, and then probably the narrowest point which takes the device to occlude the fistula should be again planned before. And this was done by a 6 French femoral sheath, and then probably 6 French was taken. Basically, the device could go even through 5 French, but to have additional wire axis of 1/4 to have a anchoring and probably not to lose guide catheter sheath in between, such wire technique was used and shown very well by Dr. Nageshwar. The Konar MF device was preferred over to the previous devices which come from Amplat's family or the vascular plugs, is basically because of the thin nature of the Konar MF, with again with the device discs on both sides with central closure mechanisms of this Konar MF, and The very fact that it's more thin and low profile could allow it to go into 5-inch sheets also, which are very useful again in closing fistulas in younger and smaller children. And we should be all congratulating and thankful to Dr. Nageshwar, who did this pioneering work and engineered and patented this technology of conar MF device, which has helped in a lot of patients of VSD retrograde closures and then such fistula closures world across. The data which has come up not only in India but from all across the world. And congratulations, Dr. Nageshwar, for making this possible for treatment of these sick and small children with this newer device. What was also discussed was what are the precautions to be taken immediately post-procedure, and then we should always keep a watch, because sometimes this thrombus could extend proximally into the coronary arteries, could develop thrombosis, and patients could rarely develop myocardial infarctions too, which should be effectively tackled with medical therapy if at all if it is required. And then long-term complications which would happen in these patients were also highlighted. So probably usage of small-dose antiplatelet drugs were also discussed in this patient of this coronary AV fistulas. One thing which was unanimously accepted and decided and messaged by all panelists, including Dr. Nageshwar, is we should close these shunts only if the shunt is more than 1.5:1. And the larger the shunt and more dilatation of the chambers of the heart and LV dysfunction and heart failure presentations, the more earlier the defect needs to be closed. By and large, we need to also to close the defect as and when the child grows a little without much of problems, provided the heart failure gets under control. So these aspects of coronary AV fistula closure and usage of the guide catheter along with the coronary wire also gives us impetus for all adult intervention cardiologists and coronary intervention specialists also to have good networking with the pediatric colleagues. That's how we could do good combinedly to these patients of children and to bring out some new interesting other procedures like ductal stenting. Again, was extension of coronary stent usage in the ductus, and then the same device was also being used for VSD retrograde closure, where all the looping, all other mechanisms were removed and the procedures are made simplified. So we wish there will be more and more collaborations between the adult interventional cardiologists and our pediatric cardiology colleagues, who are of great help even in occasionally some complications which are produced post-TAVR and all that. All of us should become comfortable with the usage of these plugs, because sometimes this could be used even in the paravalvular leaks which can happen post-TAVR. There are instances where we close those defects using the same devices. Thank you, Dr. Nageshwar, for making this possible for us. Hope all of you liked this live transmission and learned a lot of things of closure regarding the coronary AV fistula. Thank you. Yours, Dr. A. Srinivas Kumar. Thank you.